Hi, my name is Armando Rodriguez, and I'll be presenting a case that I was exposed to during my ICU rotation. The title for my poster is Malignant Triad of Encephalopathy, Microangiopathy, and Renal Failure. This was a 65-year-old Haitian female with non-hypertension and worsening diffuse headaches, blurry vision, and nausea for over 2 weeks. Upon arrival to the ER, she was noted to have a blood pressure of 278 above 158 millimeters of mercury. Initial workup did reveal the thrombocytopenia, a non-oliguric acute kidney injury, and a normocytic anemia of 6.3, with elevated LDH and total bilirubin. Also decreased haptoglobin and evidence of fragmented RBC without schistocyte on peripheral smear was found. This all consistent with intravascular hemolysis. The patient did soon become encephalopathic, and other brain imaging did reveal extensive cerebral edema. The initial 24-hour management consisted of an intravenous nicardipine infusion with goal of 20 to 30% reduction within the first 6 hours, followed by a target systolic blood pressure between 140 to 160 millimeters of mercury. Other causes for intravascular hemolysis were excluded. Patient symptoms did improve, but renal dysfunction persisted despite 24 hours of normal tension. A tissue biopsy was obtained and showed severe hypertensive nephropathy with thrombotic microangiopathy, acute tubular injury, and focal global glomerulosclerosis. Patient did require prolonged hemodialysis even after being discharged, and the 1-month follow-up showed resolution of the cerebral edema and the microangiopathy. The main focus of this case is to highlight the organs affected during malignant hypertension, define the new modern consensus of malignant hypertension, and to create awareness of the morbidity associated once the kidneys are involved. The old definition for malignant hypertension takes into account the findings of papilledema. This is limited to the physician's ability to perform a good fundoscopy exam. All this creates a delay in therapy and may even create a possibility for misdiagnosis. A modern consensus defines malignant hypertension as a blood pressure above 180 systolic, above 120 diastolic, but accompanied by end organ damage of at least 3 different organ systems, and this case fits this definition. A little more over 50% of the cases actually are due to essential hypertension, and the most common affected organs are the brain, the vascular endothelium, the intestinal tract, and the kidneys. Once the brain is affected, it is referred to as hypertensive encephalopathy, not only limited to the posterior circulation, but also involving the brainstem and the cortical regions. This usually happens around 25% of cases. In this case, we can see in the images that the patient actually had edema in multiple regions, to include the cortical regions, the occipital regions, the brainstem, and even the cerebellum. Also, thrombotic microangiopathy, which is defined as a triad of hemolytic anemia, thrombocytopenia, and end organ damage, tends to occur in 5% of cases of malignant hypertension and has been associated with a typical hemolytic uremic syndrome, and failure to differentiate from thrombotic thrombocytopenic purpura may cause harm. We all know that the treatment for TTP is time sensitive and requires plasmapheresis, and this was a diagnostic challenge in this case upon arrival. The serologic profile of the family of microangiopathies can overlap, making the diagnosis challenging and commonly only confirmatory through tissue biopsy. The prevalence of thrombotic microangiopathy and malignant hypertension in kidney biopsies has been reported between 27 to 44% of cases and is usually associated with poor outcomes. Many of patients with these findings will end up receiving hemodialysis up to 12 months. The gold standard therapy for this entity continues to be strict blood pressure reduction within hours of presentation, and resolution of symptoms are often seen. The take-home point for this case is how the new consensus definition for malignant hypertension excludes papilledema, and this creates a better sensitivity to catch this disease on time. And also, it's very important that once the kidneys become involved, the high morbidity and the poor outcomes is higher. So, early recognition of this disease and early differentiation from other causes between primary and secondary causes of malignant hypertension are very important in the prognosis for patients. I hope you all enjoyed this case, and thank you for your attention.